I'm trying to stay fit and healthy. I'm a young mom with 2 little kids. Not young mom, but a mom with 2 little kids. I would go to PT and he would try to like manipulate and it would hurt and we just couldn't figure it out. And then, so I took his advice and was doing yoga and doing like really gentle yoga. In fact, it was called a gentle yoga class. And in the middle of a class one day, I was in a plank position and my arm gave out underneath me. And it hurt. I mean, it really hurt when it happened. After the class, I went and spoke to one of the trainers, who wasn't necessarily in that class, but someone I knew well from other exercise classes, and just told her what happened and said, could you help me, stretch this out or something? I'm not sure what's going on with my arm. And she looked at me and said, that shouldn't have happened.
Welcome to the Myeloma Matters podcast, hosted by the Multiple Myeloma Research Foundation, focusing on patients' experiences with and perspectives on multiple myeloma topics that matter to anyone affected by this blood cancer. In this episode, you'll learn that there are many paths forward from a multiple myeloma diagnosis, and that multiple myeloma can be a highly manageable disease. To understand how a diagnosis of myeloma is reached, you'll hear from 3 patients, each with their own unique clinical history. These patients will describe the steps they took to get on the right track for management of their myeloma, as well as how the diagnosis has affected their lives. Please note that every myeloma patient is unique. The information in this podcast is not intended to replace the services or advice of trained healthcare professionals. Please consult with your healthcare team or contact the MMRF Patient Navigation Center at 1-888-841-6673 if you have specific questions about your health. Also, if you'd like to support this podcast series, we'd love for you to leave a comment or a review wherever you get your podcasts. For most myeloma patients, the first symptoms are usually subtle. Aches and pains are common, and they may be shrugged off as the result of normal daily activities. It may take a while for patients to see a doctor. Many need a nudge from a family member or friend before they agree to get checked out. This was the case for 2 of our guests today. Jenny Shaw, who you heard from at the top of the program, was 39 years old when she started having symptoms. She had just started playing tennis and attributed her new pain to muscle strain. Her physical therapist recommended trying a gentler activity, such as yoga. But when her arm gave way during a class one day, her trainer urged her to see an orthopedist.
So I dutifully went home, showered, went to the, on-call, like a little sort of ortho on-call thing we have here, explained to the physician my symptoms, and he was like, okay, great. And then he came back and looked a little concerned and said, I think you're going to need to see an oncologist. And I'm thinking, what in the world?
Jenny's x-rays revealed that she had several lytic lesions in the bone of her upper arm. The orthopedist told her it was not a break as she had suspected, but possibly cancer.
So, of course, that was an interesting way to find out. Lots of calls to my husband, to my parents right away to be like, what the heck's going on? And then, very quickly, we were able to get appointments scheduled with my primary care doctor, with oncology, just to sort of figure out, like, what are we working with here? And good God, could there be any other reason for this, right? Any other explanation?
Michael Milano also dismissed his symptoms as related to normal wear and tear. He had just retired after 38 years in the field industry doing heavy manual labor and was doing a lot more travel at the time to care for his mother while she was sick. When he started feeling back pain, he chalked it up to age and work.
I never put really 2 and 2 together that it could be anything other. So, I muddled through it, and I continued to travel back and forth to see my mother and get her situated and work with a team down there for her. And then actually, when I was coming back, my wife goes, well, listen, if it doesn't get any better, why don't you go see an orthopedist, take a look, and we take it from there. But, like anything else, you get busy and you get caught up, and you just really push it away because there was other priorities at the time.
After Michael's mother passed away, he finally met with an orthopedist. Initial x-rays and blood work were normal, but after a month, his pain was spreading into his lower back and shoulders. He made another appointment, and an MRI revealed that something was indeed wrong.
Once I went for the MRI, actually probably about 3-4 hours later after the MRI was done, I received a phone call from my orthopedist saying, I see something there that I'm not very happy with, and I want to start moving forward with some tests.
For some patients, symptoms other than pain can cause a medical emergency that leads to a myeloma diagnosis. This can include bone problems such as compression fractures in the spine, also referred to as vertebral collapse, or other effects such as pulmonary embolism or blood clots in the lungs. This was also the case for Steve St. John.
I had had a complete physical in April and got a clean bill of health and started to develop pain underneath my right ribs that just was getting progressively worse. Mainly in the evening when I would be lying down, it would get almost intolerable. So my wife finally put her foot down and said, "You need to go see somebody."
Steve called his family doctor, described his symptoms, and was scheduled to be seen first thing the following morning.
He did a full exam, could not find anything. So just out of a precaution, he said, "Let's do a CT scan just to make sure there's nothing going on." And unfortunately, in the CT scan, I sort of lit up like a Christmas tree. So I had two things going on. One was pulmonary embolism, pretty severe case of PE, and then also a strong presence of lytic lesions in multiple locations on my skeleton. And I remember at the time I was more upset about what am I doing with PE. I was 59 years old, good health, active, traveling, working. So I'm thinking, what am I doing with blood clots in my lungs?
Because multiple myeloma is a cancer that starts in the bone marrow, where blood cells are produced, it often causes problems in the bone and blood. These can include bone damage, pain or fractures, as well as low red blood cell counts or anemia, and abnormal blood labs. The effects of multiple myeloma on the blood can lead to other health problems, including an increased risk for infection and reduced kidney function. Receiving a diagnosis of multiple myeloma is a life-changing event. Multiple myeloma is a rare type of cancer, accounting for only about 1.8% of all cancers and around 10% of blood cancers. Patients and their families often find themselves having to learn a lot about the disease itself and the types of treatments that are available.
So for me, of course, trying to be healthy my whole life and working my whole life and not really having any other issues than maybe a wisdom tooth pulled. You get the word that you could have cancer and it's multiple myeloma. Didn't really know much about multiple myeloma, I could tell you that. But did research and we had a good team and we discussed options at that point in time, and that's really how it all started for me.
Although every myeloma patient is unique with regard to the course and prognosis of their cancer, there are critical steps important for all patients to follow on their myeloma journey. Seeing the right team, having the right tests, both steps help to confirm the diagnosis and getting the right treatment. The first step toward getting the best myeloma care is finding the right team and treatment center. Because myeloma is so rare, community oncologists are unlikely to see the condition very often in their practices, and their experience with and knowledge of myeloma may be limited.
The first doctor that I saw was incorrectly, I understand now, informed that she said, well, because you're young and because you're a woman, this is much more serious and a worse diagnosis than if you were older or something. And I'm thinking, oh, great. Well, thank you, because that makes me feel better. But once I saw a true specialist, a true myeloma specialist, he negated that right away and was like, absolutely not. You are young, you are healthy otherwise, and, we're going to fight this.
For diseases that are rare or particularly complicated, such as multiple myeloma, specialized medical knowledge is important. That's why it's critical to see a myeloma specialist. Myeloma specialists understand better than anyone how myeloma develops, how it progresses, and how and where to look for it at its earliest stages. They're also more likely to have knowledge of and experience with the latest myeloma tests and treatments, which can improve the likelihood of therapeutic success.
This is a very, very specific disease with very different, and even within the disease, so many different indicators and markers and all that kind of stuff. So it became really clear to us that we needed a quarterback who was a pro at myeloma, who really only studied myeloma.
And I do think it's critical that you have a specialist. And of course, that was the first thing that jumped at me when I started spending time on the MMRF website. I'm on there at least once a week, if not daily, since 2016. That's been a real lean-in resource for me. But they were so adamant that if it's available, and I know it's not to everyone, but if it is available, find a specialist that focuses exclusively on this disease.
Myeloma specialists often work out of specialized cancer treatment centers. These centers provide care to greater numbers of myeloma patients and have been shown to help patients achieve longer remissions and better quality of life compared with centers that manage fewer myeloma patients. Their support staff, which includes nurses, radiologists, pathologists, social workers, and pharmacists, also have more experience dealing with multiple myeloma patients and myeloma treatments. Michael and Steve received their myeloma care at a specialized center, which managed all of their treatment and follow-up. For many people, though, seeing a myeloma specialist for all of their myeloma care isn't an option. If this is the case for you, you may be able to coordinate your care so that you see a community hematologist or oncologist for day-to-day care, but arrange in-person or telehealth visits with a myeloma specialist at key points during the course of treatment, such as at diagnosis, upon relapse, or whenever your treatment plan needs to be revised. This was the case for Jenny, who received most of her care locally in Virginia with the support of her myeloma specialist located in New York City.
And so we were able to work with a physician who essentially could set his ego aside for a moment and allow Dr. Landgren to be the quarterback. And it wasn't without a little bit of grumbling, but it happened and it was fine. And I believe that I was able to get started on a more aggressive track because he saw that I could.
The second step toward getting the best care is having the right tests performed, as the results of these tests can help your doctor determine the best treatment options for your disease and assess your prognosis. Many of these tests are also used over the course of disease to monitor the effectiveness of treatment. Tests that are commonly used include blood tests, such as a complete blood count or CBC, a comprehensive metabolic profile, beta-2 microglobulin, quantitative immunoglobulins, serum electrophoresis, serum immunofixation, and a serum free light chain assay. It may also be necessary to have a 24-hour urine collection performed to evaluate urine total protein, urine electrophoresis, and urine immunofixation. A bone marrow biopsy is also done to determine the number and percentage of myeloma cells in the bone marrow. Myeloma cells that are collected from the bone marrow can also be used for cytogenetic testing and genomic sequencing, the results of which help determine myeloma subtypes and support risk stratification, both of which may affect treatment decision-making.
They wanted to wait until after the holidays, right? December, we started making decisions. January 2023, I was in the hospital, and here we go, right? We're ready to rock and roll. After they did the bone marrow, they came back with all these different observations saying, okay, this is the best thing for you.
A bone marrow biopsy is always done at the time of diagnosis and may be repeated if and when the myeloma relapses. As multiple myeloma progresses, it causes small holes, known as lytic lesions, to develop in the bones. A number of imaging tests are used to locate and measure lytic lesions, including X-rays, magnetic resonance imaging, or MRI, computed tomography, or CT, and positron emission tomography, also known as a PET scan. Understanding the role of these tests and interpreting the results can be complicated and overwhelming, especially right after receiving a myeloma diagnosis. The MMRF has several Learn Your Labs education resources available to patients and caregivers to help you better understand the role of testing in your myeloma care. To access these, please visit www.themmrf.org. The final step toward the best care is getting the right treatment for your disease. There is no cure for multiple myeloma, but there are many treatment options available to manage the disease, with new ones emerging every year. Together, you and your doctor will determine a personalized treatment plan designed around your health and the specifics of your myeloma diagnosis. The goal in treating newly diagnosed myeloma is to provide symptom relief and reduce the amount of myeloma cells in the body as quickly and safely as possible. Knowing the options that are available to achieve these goals can help you and your care team work together to determine which treatment is right for you.
I mean, I did my due diligence to try to figure out what was the next step. We thought about it a lot, we read about it a lot, and, ultimately kind of made a decision together.
The standard of care for newly diagnosed multiple myeloma is induction therapy, typically with a 3 or 4 drug regimen, followed by an autologous stem cell transplant if you are eligible, and maintenance drug therapy. Revlimid and dexamethasone, plus either Velcade or Kyprolis, are the 3 drug regimens most commonly given to patients with newly diagnosed myeloma. Both Michael and Jenny received this type of upfront treatment for their myeloma, including a stem cell transplant.
We discussed what was the best outcome, so I decided to go with the stem cell transplant based on my age, based on my health, based on my overall condition, and they felt that was the best direction for me to move forward. So again, you go home, you discuss it with your family, and you put it all out on the table, and you try to figure out what's the best thing for you and your family as you're moving forward.
In certain circumstances, such as for patients with kidney disease, cyclophosphamide may be used in place of Revlimid for induction therapy. This combination is referred to as CyBorD. Steve received the CyBorD regimen for his initial treatment with good results.
But I responded right out of the gate and actually achieved a complete stringent remission just during that 16-week induction therapy. And I remember Dr. Anderson telling me those that respond really strongly out of the gate tend to have better longer-term outlooks in terms of how they respond to future treatments. So immediate response to the induction therapy, and then sort of phase 2 was in October of 2016. I transferred to that team, and then they did the PET CT scans, bone marrow biopsies, the FISH workup, and all of that, and started to go through that preparation for the transplant.
After induction therapy, myeloma patients who are eligible, based on their overall health, will receive an autologous stem cell transplant. The goal of this treatment is to replace healthy bone marrow cells after high-dose chemotherapy. This can improve the chances of prolonged remission, but it is a physically and emotionally intensive process for many patients.
It's difficult, right? It's difficult. You're away from your family. Your family comes to see you. They have to be, fully gowned and safe, and making sure that you're safe. And so if that was probably, I have to say, one of the biggest challenges that I went through since being diagnosed with this disease.
To learn more about stem cell transplantation in myeloma, be sure to check out the episode on this topic. Maintenance therapy is given to some patients after induction therapy and potentially after stem cell transplant to help prolong the time before the myeloma returns. Maintenance therapy increases the length of time you are in remission and may help improve survival, but it's also associated with side effects. Some common but manageable side effects include diarrhea, nausea, and peripheral neuropathy, a nerve condition that causes a tingling in the hands or feet. For Michael, Jenny, and Steve, learning about multiple myeloma and finding the right care team gave them the knowledge and confidence they needed to be more involved in making decisions about their care.
I started learning about the multiple myeloma research, and I started, looking and digging down into that on my own. And there was comfort there because also I had the opportunity to speak with other mentors, right, that had it, that went through it. And I felt more comfortable speaking to individuals that had it, that went through it, that are going through what I'm going through, versus speaking to somebody that doesn't understand what the multiple myeloma or what cancer is.
To learn more about the experiences of patients who have newly diagnosed multiple myeloma, let's turn now to Jenny, Steve, and Michael, who joined the MMRF's Mary DeRome to share their perspectives on multiple myeloma diagnosis and treatment, including how living with myeloma has changed their lives.
In hearing your stories, everybody seemed to have been diagnosed after experiencing months of pain, which was brushed off by doctors and others that you consulted as just normal wear and tear of life. And I think that this is a fairly common thing that many myeloma patients go through, and it does tend to elongate the amount of time between when symptoms are first felt and then when diagnosis comes, which is not necessarily a good thing for patients, because the more time that elapses between when you start feeling symptoms and you begin treatment, the more opportunity you have for organ damage and bone damage. So knowing what you guys know now after you've been diagnosed, would you have done anything differently when you started feeling these symptoms? Is there anything that you think you could have done or that you could have done sooner? Mike, let's start with you.
Well, that's an interesting question. I thought I was doing everything right. I went to the chiropractor and I went to PT and I work out. I'm pretty active. I consider myself. I thought I was on the right track. I was doing everything right. And then, the pain never really went away, and it triggered me to move forward. My wife was like, we got to go to an orthopedic and take it from there. So I thought I was doing everything on the proper channel. Would I change anything? Probably not, because I never realized that I had anything. I thought it was just wear and tear and, part of life, right? I was always physical, always worked, and I figured, that's what it was. But when the pain became too much, it triggered me to move forward. And, I went to, like I said, I went to the orthopedic, and from there, the orthopedic triggered me to go for some MRIs, which at that point in time, it spurred on, other things that alerted me that it could have been something more severe than what I was thinking.
So Jenny, you had an experience where I think that you were speaking to a number of people about the symptoms that you were feeling, and really you weren't getting much satisfaction from anyone that you spoke to about why you were feeling this pain until you were in a yoga class and essentially, injured your shoulder or your arm when you were doing gentle yoga. So thinking back on that experience, is there any way that you think that this could have been handled differently, either by you maybe being more forceful with the people that you were talking to, or if they had actually paid better attention to what you were actually trying to tell them?
Yeah, it's hard to say. I mean, I went, just like Mike, I went to PT, and I actually think I was in the manipulation with the PT got more injured because he was so aggressive. And also, like Mike, I'm pretty fit and active, and so I think I had taken up tennis recently, and he was like, "Oh, that might be a little much for you right now, and how about you don't take up a new sport right now, and let's just focus on swimming and yoga," which is what put me in that gentle yoga class. Yeah, so I think that because I was not a typical myeloma patient, I didn't look like the typical myeloma patient. I was young, I'm female, I'm thin, all of those factors, it was not on the radar. And so it was just a huge shock to everybody, including the poor doctor who saw me in the on-call orthopedics clinic when I came in after the yoga class. He was a little surprised to share with me that was the issue.
Okay, Steve, let's hear about your situation and when you were diagnosed. You had pain in your ribs?
Right. My pathway, I guess, was a little unique. I had, in April of 2016, I had my annual physical and received a clean bill of health and was diagnosed with myeloma in June. So what transpired, I started to develop pain underneath my right rib cage that was sort of a low throbbing pain and just got progressively worse. Bothered me at night laying down, but when I would get up, I felt fine. So this is a type of scenario that you continue to put off. And finally went back in to see the family doctor. Actually, I left him a message and said, here's what these symptoms are. And he called me at home that night and said, I want you in the office first thing in the morning, 7 a.m. when I unlocked the door. So he obviously was concerned about that. Could not really find anything, but he requested that I do a CAT scan just to cover all the bases. And unfortunately, I lit up like a Christmas tree. During the CAT scan, I had significant pulmonary embolism, so which are blood clots in your lungs, and a significant presence of lytic lesions on my bone structure. And to the other two patients on the call here, I was in great physical condition. I was 59 when I was diagnosed, but very active, non-smoker, moderate drinking, all that. So I was in really good physical condition. So I was most shocked that what am I doing with blood clots in my lungs being this healthy and at this age. And by that afternoon, I was being informed that I had bone marrow cancer and it was multiple myeloma. So, what could I have done differently? Nothing in that respect, but I did have significant fatigue for about 9 months leading into that diagnosis. And I travel extensively at the time I was. So you just figure, well, I'm just wearing myself out. I need to rest more. Maybe, don't exercise so hard. But the fatigue was getting really bad where I would be sitting in a meeting and I would literally be thinking, if I don't stand up, I'm going to fall asleep. And that's not the way I've ever been. So that was really the only symptom. And a lot of people asked me about that were colleagues post-diagnosis. Was there anything you saw or could have known? And for me, I probably should have been more aggressive with my doctor that this fatigue is a significant issue. I just put it off to overwork, too much travel, that sort of thing. So the blood clots are really what got me in there, got me diagnosed before this disease got too far along.
I guess that's kind of, in a way, that's good, right? Their diagnosis wasn't prolonged. And some people go for a half a year or a year with these terrible symptoms before they get diagnosed. I mean, the issue there is that myeloma is such a rare cancer. It's only 1.8% of all cancers. And when a patient steps into your office and, you have testing done and you have anemia and you've got bone pain and maybe your renal function is not that great, it's seldom the first diagnosis to pop to the top of the mind of the physician that you're seeing. Because many of them see very few patients, if any, especially if you're just going to your primary care provider. They just don't have the experience with the disease. So let's talk about finding a myeloma specialist and a care team once you have been diagnosed. So Jenny, how complicated or how easy was it for you to sort of transition from your community care doctor to your specialist?
I was very fortunate that I had an aunt who was working at Memorial Sloan Kettering in New York at the time of my diagnosis, and we were getting sort of very gloom information from my local doctor that I had sort of just been thrown out to once I got this diagnosis, and so we knew that we needed to seek other opinions, and so I was very fortunate to get in very quickly with Ola Landgren, who's now in Miami, and able to sort of get a workup with him and start learning about my options. I also was able to see a specialist in Boston. I live in Virginia, so there's a lot of travel and some exhausting days. But once I decided that I wanted to have Dr. Landgren, I call it quarterback, the whole process, it was pretty good to work with my doctors in town in terms of having Landgren be the quarterback and letting them sort of help run the plays. It wasn't always easy. There was some pushback, but I think that most of the doctors I've had and worked with in Virginia understand that it's a complicated disease and that they don't know everything about it. And so in some ways, I think especially this last one I had was really kind of looking at it that they could learn a lot from him and from the ideas that he had, the drugs that he recommended, the protocols that he was running were different than what they had heard and what was sort of the antiquated ways of handling myeloma.
That's still, believe it or not, that's still fairly common, that people will go to the doctor and get diagnosed with myeloma. And, the standard of care therapy is taking either a triplet therapy or a quadruplet therapy, and they'll be given a doublet therapy, right? That happens, unfortunately, all too frequently. So this is, one of the reasons why it's so important to consult with a specialist. Steve, what about your story and when you were diagnosed and transferred over to UT Southwestern?
I was, and I love the woman that diagnosed me, but unfortunately she was not a myeloma specialist. So I did stay with her right up until the transplant. And then her advice at diagnosis was, I don't think you need a second opinion with respect to what you have. We have a pretty good handle on that, but you might want to consider meeting with a team that specializes in myeloma. So she was very open about that. So she worked with me up until that transition. So at transplant date, I moved over to Dr. Anderson at UT Southwestern, who's just an absolute wonder in terms of myeloma care, and have been with his team the entire time. But she did a great job getting me ready for the transplant, and I just think it's so critical. She was very vocal about spending time on the MMRF website. That's how I got turned on to that, was through the original oncologist that diagnosed me, and that's where I sort of got this mindset that I don't need so much a second opinion. I need to look at someone who specializes in this disease. And, myeloma is so complicated. And the other issue for me is the treatment landscape is so rapidly changing. I thought it was rapidly changing in 2016 when I was diagnosed. It is crazy right now with what is not only approved, but what is in the trial phase. And I like to do research and keep up with this, and it's just out of reach to get a handle on all of that. But those two dynamics alone, I just think if accessibility is available to you to have a specialist, even if you have to commute, I would just strongly urge to take that path if you can.
Mike, what about your story?
Yeah, it's pretty much the same as everyone else. I mean, when I received that phone call from my primary doctor. Then when I went to the orthopedist and the MRI came back, my primary doctor called me, and I was on the road with my wife, and we had to pull over to the side of the road because I couldn't really make out what the conversation was. And then I was on the side of the road probably for a good half an hour as he was explaining to what he thought it was, and we were like, it's cancer, and we were like, and he was like, yeah, I believe this is what it is, and I believe it's multiple myeloma and the whole 9 yards. And we were just kind of looking at one another like, oh, we were like, what is that? Never heard of it. And he referred us to a blood specialist, and like within 2 days received a phone call from Northwell Health Group, and I was lucky enough there really wasn't much travel involved. It was close to my home, so I was able to meet the team from Northwell that specialized, and like everybody else, there's so much dynamics of this is moving, and what's the next step. And I went through the induction therapy with the 3 drugs that they thought was the best bet to do. We didn't want to waste any time based on my age and my health, so we were on a fast track to try to work with this and keep everything at bay. So, we set up PET scans, we set up everything. Everything was just quickly moving. It was, I can't even explain it, because from when it started back in June to where we are today, it's just unbelievable, the movement of everything. So yeah, I mean, I've been lucky. There was a good solid team around me, looking at the blood work, giving me direction and thoughts of what the best direction to go, the planning. That's pretty much where I'm at this point. It's just you scratch your head, because there's this, like Steve says, I mean, there's so much technology out there. It's like, we're going to do this, we're going to do that. And then you're staying on track with the 3 drugs that I was given. It seemed to help me, to get me to where I'm at today.
Good. So, I mean, I think it's an extremely common occurrence that when people are diagnosed with multiple myeloma, their first question is, what's that? No one's heard of it, right? And yes, people can tell you it's a cancer, but it has very little in common with the most common cancers like lung cancer or breast cancer or colon cancer or prostate cancer, because it's really a blood cancer, which is extremely different. So Mike, when you were diagnosed with this, and then did you decide that you really needed to learn about it and really educate yourself about the disease, or did you just sort of like leave that to your physicians?
No, I didn't. As soon as I found out about multiple myeloma, I started doing my research. Not always a good thing to do your own research, right? You're reading some stuff that you really don't want to read about, and but I wanted to just get the basics. I wanted to get the knowledge of what it was and what could be done, because probably like everybody else on this call, what could we do to resolve it? Right? What could we do to work with it? I'm not the type of person that sits back and just waiting for the results to happen. I'm all in. What do we need to do? I listen to my team. What's the next step? Does it make sense? I felt I didn't need a second opinion because I basically did a lot of the research myself, and I knew what was going to take place, what would have happened at Sloan's, and what have happened at some of these other locations as well. They were on that track of the myeloma track, so I felt comfortable with that. And then was lucky enough to get turned on to the MMRF, which was very helpful, the websites, and then talking to other patients and other mentors out there. That we had it since 2016, we had it since 2017. Those are real life people that you want to talk to, right? And not listen to something on a webcast that you're not upfront with, So I felt that made me feel comfortable, and we were heading in the right path.
Certainly, there's places to get information that are not so great, as you mentioned. So it's always good to do your research, as you mentioned, and touch base with an organization who knows a lot about multiple myeloma to get the best and most trusted information, right? So Steve, tell us about how you learned more about myeloma once you were diagnosed.
Well, to second what Mike said, I dove right in. I want to know everything about what I'm facing. So my wife's the exact opposite. I don't want to know anything, just let the doctor run things. I want to know, and I want to be empowered with that knowledge. So I initiated extensive research, which I do to this day. I did get some good advice right out of the gate, which is to be really careful on the internet. And I remember back in 2016, when you would go in and Google myeloma, you would see that 1 to 3 year death sentence. And I was stage 3 at diagnosis, so I'm thinking, well, I've got a year to year and a half to live based on some of these websites. And I knew that wasn't the case, just because they had forewarned me that I was going to see that type of data. And so much cancer data can be stale as well, depending on the website you're on. So I started to leverage the MMRF and Leukemia, Lymphoma Society of America, just sites that I know are safe to use. And then some of the treatment centers like a UT Southwestern or a Sloan Kettering or MD Anderson, you can find very good, valid research data on myeloma there as well. But I think it's important to look at reliable sources. And I just wanted to know everything I could about the disease, what the outlook is, good or bad. That's how I psychologically prepare for treatment, and that's how I psych up. So I want the doctors to have an open line of communication with me every time I go in. What's the status? What are we looking at? What signs are you seeing? What do we see going forward? So, but I'm all about being empowered through research. But just be careful with the resources you use, because you can find some misinformation out there that will scare you. That's unnecessary. There's such progress right now. If you're on any legitimate myeloma website, I would think there's some pretty favorable and positive information on there right now from a treatment perspective, as well as a diagnosis perspective that wasn't there in 2016. So a lot changes quickly.
That's very true. So it's as an organization that tries to keep patients updated with everything that's happening in myeloma, we have to really literally refresh our materials every year. That's how rapidly this field is evolving. And there's so many great new therapies that are in development or have been developed for patients that are really making a difference. Jenny, can you tell us your story about, once you were diagnosed, did you try to learn more about myeloma and what sources you used to get your information?
Sadly, my diagnosis with myeloma was not news to, the concept was not news to us. My husband's father had actually died about 6 months before from myeloma, which made us have more information than we really wanted at the time, to be honest. He was in his 70s, I was 39. So that was a real scary thing to know a whole lot about it, and to have had my husband watch his dad go through 2 stem cell transplants over the last 15 years. So we knew a lot going into it, but I think what gave us the most hope was that the new things we were learning, we were realizing that the myeloma of 2015 was really different than it was when my father-in-law had been diagnosed. So we really latched on to that and tried to get as much information as we could.
Let's talk a little bit about, having the right tests done when you were first diagnosed, right? So Mike, can you tell us a little bit about the testing that you had done when you were first diagnosed, like the bone marrow test, imaging test, blood test, things like that?
Yes, well, yeah, we pretty much did all that. Did the bone marrow test. I went in for the bone marrow, and that came back, showing me that there was definitely traces of multiple myeloma within my blood area. And then we did the urine test, all right, that 24-hour urine test to make sure where we were with that. All of those tests we did all came back positive results for multiple myeloma. And that was the one that was able to trigger me to what's the next step from this, okay? Because where are we going from? Where are we heading down the road? Okay, what's going to happen at this point in time? It was all new to me. It's like talking another language. Even to this day, when I'm hearing certain things, it's still unbelievable to me that I'm going through this at this point in time, right? I mean, a year and a half ago, never thought that I was going to have any issues in life. You hear about other people with cancers and my friends and other family members you hear about, but you never think it's going to be me, right? So instead of sitting there and in the corner, what's our next step? So I was thankful that I had a good team and put me through these different type of testings. Put me through the auto transplant, and we talk about it today that there's so many different opportunities out there. So that's basically where I'm at, Mary, with this.
Yeah. Did you feel like when you were undergoing this testing and you were getting the results of the test from your care team that they explained it to you in a way that was kind of easy to understand, so you sort of got the gist of what was happening?
Yes. Me and my wife we want to put it in like vanilla terms, right? Because we don't know the technology of kappa light chain. What's a kappa light chain? Never heard of it ever, right? We when we talk to our doctors and we talk to the team, we had them explain it to us in such a way that it was, if I had to talk to my neighbor or talk to somebody, they would understand it, right? And that made me understand it, right? Well, what does it affect? Why does it happen, right? So we put that into terms that was more speaking vanilla, so that it was understandable. It made me feel more comfortable knowing that.
Yeah, that's great, actually. The ability of you to communicate with your care team and their ability to communicate back to you in ways that you can understand is like vitally important to make you, feel like you have some control and some knowledge of the situation, right? Especially when when people ask you, so how are you? How are things going with your treatment? You can actually answer them in ways that they can understand, right?
That's the most important piece out of it, making sure that you understand it and you're getting the proper knowledge back from your team. Because you hear it all the time on a lot of these calls that I hear you on, Mary, with some of these doctors, and I get off sometimes and I'm shaking my head because they're so highly intelligent that they're speaking at levels where it's all good stuff, but if I had to explain it, I couldn't do it.
I agree. And, some of them are better at, speaking at a patient level than others, right? So some of them they find it difficult to really sort of come down to the level that they need to make sure that the point that they're trying to make is actually getting across to the patient, right? In a way that the patient can understand it. And so sometimes, maybe the doctor is not the best person to talk to like the research nurse or somebody like that, and they can actually talk to you in, better in ways that you can understand it better than the doctor, because they're kind of like,
Yeah, but you know what? I think through my education and educating myself on the terminology, I'm able to go back when I go back for blood work and I meet with my doctor. I have some notes that I'm able to talk to them and bring up some things that I see on my chart, And I think sometimes, well, I wouldn't say, they're looking at it as like I'm becoming more educated, but yes, I'm becoming more educated in something that's affecting me.
Yeah, exactly. So Jenny, when you were undergoing your first, battery of tests when you were first diagnosed, does anything stand out to you as something that, you found surprising or shocking, or did you have an easy time talking to your care team and understanding what they were trying to get across to you?
I think the whole time I kept thinking, okay, the next test is going to say this is not cancer. Like one of these tests is going to throw this whole thing off. Yeah, because we did not sign up for this. And so, with each test coming back, just like Mike said, positive, this is it. This is really myeloma. It's really myeloma. I just remember being so surprised and, kind of confused by it all and trying to figure out how the lytic lesions in my arms and my ribs, how that had to do with the elevated levels in my blood and, learning all about it. And it's complicated stuff.
So Steve, tell us about, some of the testing that you have done and what you sort of thought about that, and did you understand it, and how your care team was about explaining it to you?
Yeah, and it happened at such a fast pace. I mean, I went in and, did the CAT scan, ended up being hospitalized for the pulmonary issues, and then that afternoon, probably about 4:30, Dr. Chachuri came into the hospital room and said, let's clear the room out so I can have a visit with you and your wife. And that's not a good sign. So we're thinking, here comes a very heavy conversation. And I remember her walking over and saying, you have bone marrow cancer. This is multiple myeloma. And we haven't done a single test yet to validate any of this, but I'm looking at a healthy male presenting with blood clots in his lungs and lytic lesions on his skeleton structure. That's what you have. She even went so far to say, I think you have what is known as Vince-Jones myeloma, which turned out to be the case, which is kappa light chain myeloma, which is 15 to 20%, I believe, of cases that are diagnosed. So I remember her telling me, you've sort of hit the cancer lottery here, but the good news is there are a lot of people in the oncology community that are going to want to spend time poking and prodding and looking at you, depending on who's in charge of your care. But she put me in surgery the next morning to do some extensive biopsy testing. So I got to sleep through my first bone marrow biopsy, which was great. And then I got to celebrate the real deal later. But that following Monday, I was in the hospital over the weekend. And that Monday, it was just a barrage of tests. So I was relatively clueless about the FISH panel and, the light chain assay and all these various tests they were doing. I was just waiting to hear from them. Have we positively validated that that's what you already know I have, which was the case that following week. So it occurred fairly quickly. But PET scan and full body x-rays, the whole array of tests that they do. And it was really just done to validate what she had already pretty much had her head set on, that I had that. So I was always amazed she was able to make this call, just observing me there in the hospital. But she's a renowned hematologist, and she was spot on. And then we reached out to Dr. Anderson's team at UT Southwestern. They did the test themselves pre-transplant just to make sure they validated exactly what we were contending with. So, and I did proceed with the transplant in November of 16, autologous.
So Steve, did you say that when you were diagnosed, you were stage 3?
That's what I was, because of the lytic lesions. Under the original jury system, if you have the lytic lesions presence to the degree I had, that automatically put me in that category. And then my light chain count, I don't show anything on the new international system. So the beta 2, all of those, I don't have any markers. I don't have the M spike. So with the Vince-Jones, the only thing that they really can confirm or track are the light chains. And thankfully, there's a blood test that they can do that will just tell you within 24 hours where those chains are. Are they going up, going down? So I anxiously await that result once a month just to see the directional trend in my light chains.
So do you know whether your myeloma is categorized as high risk?
I'm considered standard risk. I did ask them that. I have the KROS and I think the CD56 marker. I can't believe I throw these terms out. It's amazing what we are educated with as we go through this process. I was like Mike. I went from not knowing anything, but as of last week, I've been 7 years since diagnosis. I learned a lot about cancer and certainly a lot about myeloma over those 7 years.
Jenny, was your myeloma staged when you were diagnosed? Did they tell you what stage you were?
I'm not sure that they did. I mean, I definitely had lytic lesions, so I'm not sure that they said or that I asked. I don't know. It was definitely, I had lytic lesions everywhere throughout basically my whole skull, like my arms, my legs, my pelvis, my ribs. It was not brand new. Let's put it that way. It had been around for a while before it was detected. But I don't remember them giving it a number.
It's a little bit different in myeloma than, as compared to other cancers, right? Were you staged, Mike, when you were diagnosed?
No, I was pretty much on the same page. They didn't really stage me. They just basically called it multiple myeloma, and that they weren't really, it wasn't really a staging process. They could have told me it was stage 15 and it wouldn't have mattered because it was, what are we doing, right? What's our next step, right? And let's do it, and let's whatever we have to do to look and help resolve and get better and move forward. That's what I wanted to do, So to me, I don't think it really mattered what if they would have told me what stage. I don't really, it would have probably not mattered at that point in time. But as I hear Steve and hearing what he, was up against, good to hear that it's 7 years, and that's what I want to hear. That's my direction.
Do you know, Mike, whether or not they've done a bone marrow biopsy on you and they have tested your cells for any genomic abnormalities? They talked to you about being high risk or standard risk?
I don't remember hearing that conversation. I might have heard it, but I've been on this fast track since since it was diagnosed, and it might have been said to me, but between me and my wife being in the room, we both leave there like, did we get everything? Did we get all the conversation? Did we get all of the knowledge that we need when we left there? So I'm sure it might have been said. I'm from the school of, okay, I believe it. Let's just move forward. Maybe I should, like Steve, maybe, dig into it a little bit deeper, a little bit this, but, I go by how I feel. I go by how the testing is, and then let's just continue to move forward where we're at.
Jenny, when you were diagnosed, or even since you were diagnosed, do you remember anybody talking to you about whether or not you're high risk or standard risk?
I think that because it must have been pretty advanced by the time it was diagnosed. They were thinking that, I don't know if they called it high risk, but they were able to start me on a drug that's typically for, refractory, thinking that I probably had like smoldering myeloma for a while and didn't know it. So I got started immediately on Kyprolis, and that was able to, literally after one infusion of it, my numbers plummeted. It was amazing. We were celebrating big time. And that was part of the whole idea of having a specialist, because, my doctors in town were just like, okay, this is what we're going to do. We're going to do, Revlimid, the VRD regimen. And the specialist was like, nope, let's try this instead and let's make this work. And we were so grateful that we were able to.
So Mike, you're on RVD, right? Are you still on that?
When I started induction therapy, I was on Revlimid, I was on the steroid, and I was on the Velcade. So they started me on that. I did, let me see, it was like 5 total sessions prior to my transplant. And, it was 28 days on, and then you had a couple of days off that break, prior to my transplant. And everything was looking good at that point in time. So I was on a 3-drug regimen.
Steve, it looks like you were on actually Cybor-D. That was your initial treatment, and that probably had something to do with the fact that you have light chain only myeloma, which affects your kidneys more. Cybor-D is usually a therapy choice for people who have renal insufficiency. Did your doctors say something like that to you? Yes,
and I didn't have any renal issues, but I think just given the diagnosis that they opted to use Cytoxan in lieu of having Revlimid there with the Velcade. And to Jenny's point, I responded immediately. My counts plummeted after the first week or two of that induction regimen. So that by the time I got to transplant, I was in stringent complete remission, which it's always good to respond coming out of the gate because that tends to show a better history of responding to treatment down the road as well. So I've always responded very well to what they've put together and thrown at me. So, and that continues to this date.
Did any of the three of you feel that you needed to have a second opinion when you were first diagnosed and you wanted to have another doctor sort of look at your case? Steve, when you were saying that you went from your doctor and you had all the testing done in your primary doctor and then you went to UT Southwestern and they did all the same testing again and were able to confirm the same information. Jenny and Mike, did you sort of have that same process, or do you just basically went to the doctor and then you just did what they were telling you to do?
I did seek out separate opinions from two different institutions other than our local hospital. Not necessarily to confirm. I mean, I knew the diagnosis was what it was. Unfortunately, we figured, even though we wished that it was going to be something different, we knew what it was and we knew we needed to deal with it. Really, the consultations I wanted to have is to find a doctor who I felt like I could really trust, who was a specialist, and also to really decide, did I need to do a transplant? Like, was that really necessary? Like, that was going to be a lot. As I had said before, my husband watched his father go through it twice. And knew how hard that was on him physically, emotionally. Our kids were ages 4 and 6 at the time. They needed their mom, and so we weren't real excited about the idea of doing a transplant. So that was really my reasoning for going to have multiple opinions, to make sure that people really thought that was necessary. And the answer was, yeah, they thought it was. And so we did it.
I mean, even despite, there's a lot of work going on to really determine, whether or not people can do transplant up front right after they finish induction, or do induction and then go on consolidation, go on maintenance, and then when they start to perhaps relapse after being on maintenance for a period of time, then do the transplant. But I think that the data has shown that it really is still standard of care to do induction and then do the stem cell transplant if you're a candidate for that. And basically that's what all of the three of you did. You had your induction therapy and then you had your transplant. And when I think about going through something like that, it just seems to me to be it's got to be hard. Right? It's got to be hard to go through a transplant. So who wants to tell me about their transplant experience?
Well, I could definitely jump in and speak to it. It's mind-blowing because, just of the documentation that you have to read and understand what you and your family and what you're up against and what the complications can be. Because it was made very clear to me that there could be complications. There's no guarantee. And when you start hearing words like that, you start looking at yourself, you start looking at your wife, you're looking at your family, and it's just a lot that goes on through your mind. But I knew, based on the direction that I needed to go, I knew based on my team that it was the way to go, and I didn't want to wait. So yes, I was went through the procedures, I went through the induction therapy. I went through all that. My numbers were looking good. My numbers were getting better. And, January of this year is when we went through it. And, went to North Shore University over in Manhasset, the great team over there. I got to tell you, it was definitely an experience that very difficult to go through. You're there and the team is around you constantly. And, you're in a room by yourself, you're isolated, visitors, my wife would come, my daughter would come, and you'd be, you're dressed up in this wear where, you had to protect yourself and you had to be protected. And that alone is difficult. So between the blood work and preparing and going to the chemo, 2 rounds, I went to 2 rounds of heavy dose chemo. That's what I needed to do for my particular case. It was 30 minutes of chemo day 1, 30 minutes of chemo day 2. You take a break in between, after they take your stem cells out from you. And then, a couple of days later, your stem cells are transplanted back into your system again. And you can only hope at that point in time that they start doing their thing and they start finding where they need to go back into your bone marrow and start to grow and start to seed. And, you know, it's just a remarkable what happens to your system and what takes place, right? Because it's just hard to put into words, but it's just amazing where stem cells come out of you and they know where to go. By giving you, you know, injections, it's like, I call it like fertilizer to get them motivated, to get them, let's go, we gotta get back into our positions, we gotta get out there and start fighting the bad guys, you know? And that's what happens.
When they developed these procedures like years and years ago, how did somebody ever figure out that this was actually going to work?
Yeah, it's just crazy. And then you know, once they start growing and they start doing what they need to do, I think it was around the 6th of January is when they started to do their thing, and it was like a new birth. They called it for me. That was like a new birthday, right? Which was great. They come in, they celebrate, and I'm still there. So my goal was, I wanted to make sure that my cells, my white cells were coming back, my red cells were doing their job, and I was in North Shore University for 17 days total before I was released. I can't speak on behalf of Steve or anybody else, but I could tell you it was definitely trying 17 days that you're in the hospital, you know, and you're going through this, and the chemo, and then it was a difficult task. But, you know, a great team, solid people around you to make sure that every day, every hour, you know, they're checking on you and they're making sure you're good. And if it wasn't for them, you know, the conversation might be a little bit different where we are today. So it was just, you know, great knowing that the team around you was definitely on target.
So Jenny, I know you had a transplant as well. So I mean, thinking about the fact that your father-in-law had 2 of them, right? Mm-hmm. So was there differences between, you know, your transplant and the 2 transplants that your father-in-law had gone through?
Yeah, I think so. I mean, I think I was I was younger, I was in better physical health than he was at that time. And so I was a little stronger going into it. I do remember thinking, you know, I remember a few days before I was supposed to go in to actually do everything, and I remember sitting at one of my kids' basketball games, and one of the other parents who I was close with said to me, I can't believe, like, you look fine, you seem fine, and you feel pretty good right now. And I'm like, yeah, I feel great right now. Like, all the pain's gone. And he's like, so it seems kind of weird that you're about to go in and do this, like, really, really aggressive procedure, you know? And I remember thinking, yeah, you're kind of right. Like, what am I doing with this? But it felt good to feel good going into it and feel strong enough that I felt like, okay, I'm going to be able to do this. And then I was in the hospital, I don't know, 3 or 4 weeks. I had a few infections while I was there that kept me in, and you know, I was very sick. I got a lot of GI stuff while I was there, and that was really hard. I lost a lot of weight, which was concerning. But I was honestly, when I look back on it now, I was just, once I wasn't feeling terribly sick, I was just so bored. I am a very busy person, and having to sit in that room all day long was just mind-numbing. And people kept giving me coloring books and all this stuff, and I was like, I don't want to color. I want to go outside. I want to take a walk. Like, I just needed to get out of that room. That was honestly the hardest part for me.
So Steve, tell us what your transplant experience was like.
Yeah, so I spent the entire 16 weeks of my induction researching transplants, tracking down everybody I could that had had one, just to seek advice, maybe a game plan. So for lack of a better phrase, I sort of trained for my transplant. I mean, I tried to physically get in good shape, and I tried to have a game plan going in, which I put together from a couple of MDs I had tracked down that had actually gone through the process. So I had a game plan sort of set once I got in there. For me, the overall experience was nowhere near as negative as I thought it was going to be. I was a bit of an outlier. I had very little issues with nausea or side effects or mouth sores or the diarrhea or any of those things that they tell you you're going to have to go through with the side effects of the melphalan and what that does to your body. So my experience overall was not that bad. It's not something I would want to repetitively have to do again unless it was necessary. But I was in a state-of-the-art facility, so my room was filtered, as were the hallways. So I was able to walk So one of my plans every day was to get up and walk around the transplant unit and do 3 laps. So I would get out of bed. That was kind of difficult after about a week. Once the melphalan set in and I was neutropenic, it was a little more difficult to get out of bed. So my wife was a motivating factor there. Let's get up, let's walk. But that sort of kept my optimism up at a high level to do that walking 3 times a day. And I would meet the staff in the hallway and run into the other oncology teams, and they would cheer me on. So that was kind of my game plan. And then I had plans to eat, make sure I ate my meals. My appetite was fairly stable throughout the transplant, which is not the case for everybody. I got a good breakfast, a not so good lunch, and then in the evening, it was a challenge to eat, but I would do a milkshake in lieu of dinner. So I was told, if you want to get out of the hospital sooner, get out of the bed and make sure you eat food. Don't let them feed you through the IV. Make sure you eat. If you get sick, eat again. If you get sick, eat again. So I sort of had that game plan, but in terms of side effects, I was pretty blessed, I think, overall. And I grafted very aggressively on day 11. And it literally felt like they had hit me with a narcotic. I mean, it was kind of late in the evening, and I could just tell. I'm like, I just don't feel that bad tonight. And the night nurse, who was on shift, said, I heard a rumor somebody might be getting released tomorrow. So, I mean, I was just in this, euphoric mood. You literally can just tell once those stem cells do their thing and they graft in there. It was just an immediate uplift from that really heavy fatigue that you go through I describe it as sort of feeling like a rag laying on wet cement. You're just sort of flopped there and you don't really want to do anything. So you have to really make yourself get up. But again, I think that procedure is getting better and better as we go forward. So again, be careful researching transplants. My initial research was that it was just going to be this horrible experience that I would regret the rest of my life. And that was anything but the case for me and most of the people that I talked to. Not something they would want to go through, but certainly something you can get through. And I think the benefits of it are worth the whatever suffering you have to put up with to get through that.
And certainly things have progressed, amazingly since the early days when, there was a time in myeloma where transplant was literally the only thing that they had to treat the disease. And people would go through 2 of them, 3 of them, sometimes 4 of them, depending on where you were being treated, because there was really no other choice. So luckily we've come a long way from those days. So all of you guys, you had your induction therapy, then you had your transplant, and now everybody is on maintenance. Looks like everybody is taking Revlimid maintenance. With the exception of you, Jenny, it looks like you've had a little bit of a different path than the rest of the folks here. So can you tell us a little bit more about where you are in your maintenance? You were on a clinical study for maintenance for a period of time?
Yeah, I was on a clinical study for Revlimid right after my transplant and stayed on that study for about 2 to 3 years, at which point my light chain number started to rise again and was no longer eligible for that study. So I kind of got kicked out of that study, which was a good thing because my doctor really wanted to make sure that, he said, I don't want you in this study if it's not helping you anymore. And so it really kind of fast-paced us to get on to something different. So he recommended that I start on daratumumab, which I started, it's been since probably 2018. That I've been on that now. So 5 years almost. Yeah, 5 years I've been on daratumumab, and that started out with infusion, and now it's a sub-Q shot in my belly.
A 5-minute shot, right? So easy.
You think, yes, except for with the waiting time before and after of getting in the clinic. But I joke it's a 5-minute procedure that takes 2 hours.
How often do you get the Dara?
Once a month. And there's discussion with my doctor now about, I don't know that there's any research that says for sure you could go longer, but it seems like there's a pretty long half-life, and so it's possible that we could start to extend the period between getting the Dara so that maybe it would go to 6 weeks or 2 months.
That's a really interesting story that you were on a clinical study. So Steve, you were also on Revlimid, and you relapsed after that within a period of years, right?
Yes, I'm technically on my 3rd relapse. So currently I'm on Darzalex, Pomalyst, and dexamethasone. So I'm on that triplet regimen. Coming up on 24 months being on that regimen. So that's worked really well. So that's a pretty good time frame to be on that one.
I was on those 3. And then at one point I was having really bad peripheral neuropathy in my feet. And so the doctors decided to pull away the Pomalyst and the dexamethasone. And the dexamethasone, and mostly the dexamethasone just because it made me crazy. And so, but now all I do is the daratumumab.
And so, Mike, you just had your transplant just like 6 months ago or whatever, right?
Yeah, I had it probably close to 6 months ago, and now I'm on maintenance, and I've been on maintenance probably now going on my second month right now of maintenance.
And so, how has that been working out?
So far, it's good. I mean, I had some in the first month. I had some diarrhea issues that I was working through. It's still a little tricky, but it's been a lot better once I'm in my second month. So yes, it's been better with that. And, I keep my fingers crossed just listening to everybody on the call here that as we continue to move forward, that there's other things on the horizon if this doesn't work out. So I'm positive and keep solid, keep strong. I work out, I try to eat right. And, I try to stay, physical on the track and learn more about it every day. And I feel good. My pain is probably a 0 at this point in time. So I'm on that solid track right now. And, I'm feeling good. So I just want to continue that direction,
So let's talk a little bit about, and I think we've touched on this actually a lot during this podcast, about the importance of being able to speak, plainly to your healthcare team and have your healthcare team speak plainly to you in ways that you can understand. And it's really important that when you talk to your healthcare team that you sort of communicate your needs to them and that you are heard by them. Like you tell them what your concerns are and they help you with whatever your concerns are, and talk to them about what choices you have for treatment where you are in your disease journey. Talk to them about the side effects you're feeling and how they can help with that, and maybe help with stress and anxiety that you might have from this diagnosis, which is so totally understandable. And Mike, you've also talked a lot about you're having your wife by your side through all of this procedure, right? And so talk to us a little bit about, your relationship with your care team and how your wife has played a role in where you are.
It just means a lot that you have, somebody in your corner, right? That you could pick up the phone and you could speak to. And when I was in the hospital, I was able, pick up the phone, make a conversation. My wife would be there, my kids would be there, and it's just an important part that you have that support team around you, and we get phone calls from Northwell. They would call up, how you doing? How you making out? I just want to check upon you. Any questions? And that just makes you feel that much more present in that moment. It's so important to have a team around you that you can talk openly to, whether it's a neighbor, whether it's somebody that you feel comfortable with. But it's so important that you have that team around you and not take it in all by yourself, because you just can't do that. It's just way too much. From Northwell, from them calling, making sure I'm okay, and just your children. It's just a phenomenal feeling that you're going to get better. And you have them around to support that.
So, and talking to other patients is always very useful as well, and hearing their stories and what they've been through, right? It helps you really understand, some of the things that you're going through as well. And it's always great to talk to somebody who has been through or is going through the same thing that you are going through.
Yeah, and you know what, Mary? That's why I'm on the MMF site. I talk to people. I listen to the webinars. I find them very comforting to hear, doctors, and I hear other patients talk about it, that, there are good things on the horizon, and, they're looking for a cure, and when I hear that just perks you up. I heard one of your webinars, and I forget who the doctor was, and then he's working, and the bottom line was, he's saying, there's going to be a cure for this, and when you hear that, it just makes you feel like you got to continue your crusade. You got to move forward. You got to be strong, right? You have kids. Everybody on, I'm on the call. I have kids. My son just got married, and it's important, right? And when you hear that there's going to be a cure, it just makes you every day have a little bit more skip in your step, you know?
Absolutely. So, I started working in the myeloma field in 2014. And at that time, nobody was talking about a cure, right? But now, since we have these newer therapies like these CAR Ts and bispecifics and other things that people are developing for myeloma, this is the word that's, that everybody is talking about now. Over the last couple of years, it's been really amazing that, from a disease that literally had just a terrible, terrible prognosis not that long ago, the prognosis now is much better, and it's really almost become like a chronic illness, right? And there's many, many other choices for therapies if you begin to relapse from whatever you're on currently. There's always something new to go to. So I think there's really a lot of hope these days in the myeloma field that we will eventually achieve a cure. And how that will be done, we don't really know yet, but we're just sort of inching closer and closer all the time, which is really a good feeling. Jenny, I know that you went through, when you were first diagnosed, you got opinions from a number of people, and then you were going to Memorial Sloan, and Dr. Landgren was your doctor, and, he was like the quarterback of your team, and, just sort of, making sure that everything with you is going smoothly. So how important was it for you to be able to talk to your care team and get the information from them, so that you could feel like they were doing the right thing and that they were doing what you wanted them to do and meeting the goals that you had for your treatment?
I really trusted Dr. Landgren so much because he's just like a wizard and knows everything. And I felt like I just trusted him, and he also was very kind to me, and I could tell he was like, you are not going to die from this. Like, this is like, you're going to get through this. Like, you are going to, like, he just, he had confidence in the science and in what could happen. And I just felt so supported by that. Right. And so the most challenging part was for me was to be able to then, have him be able to communicate with my team in Virginia, which, like I said before, it had some challenges, but for the most part was, relatively smooth. And I had to stay strong to be like, no, this is how we're doing it. We're going to have him as the quarterback, and we're going to have the team here in Virginia to, implement the strategies. And it worked well.
So clearly you told them what you wanted and they heard what you said. So, it's a great example of how patients should be able to communicate and cooperate with the care teams and vice versa.
And I think you really do have to advocate for yourself, though, because I did have to push back on it a few times when it was like, well, no, we can do this. And no, this is what we're going to do. This is what, and my husband and I felt really strongly about it and just felt like, no, we were getting the best advice from someone who's truly a myeloma specialist. There were none in our area at the time. And so we just felt really adamant that that's what we needed.
So that's good. Some good advice. Steve, how about your experience with your care team? I know that you're being seen at UT Southwestern, which is a great center for myeloma specialists. Dr. Anderson is amazing, and he has a couple of other great myeloma physicians on his team as well. So tell us a little bit about your relationship with them and your communication with them.
Yeah, I do think it's important that you're comfortable with your team, but I also think you have to make sure you have a voice. Sometimes they may just take for granted that you understand what the procedures are or what the regimen is. And so I have a list of questions for Dr. Anderson every time I go in, every month. So they're on my phone, and he'll finish and say, okay, I know you have questions. And just during that month, things that I'm concerned about or just want to be empowered or want to know or maybe push back or challenge. So I just always go in with those questions, and he's usually able to diffuse those to my satisfaction without any angst on my part. But I think it's important that you do have a voice, and I think they want you to have a voice. If you just sit back, they'll let you sit back, and they'll give you good care. But I think it's important that be kind of interactive, and you do have a choice as to, as I move forward and start to look at potentially going to a trial or some of these other treatments, and I'm going to do some research, and I'm going to want some, pretty definitive feedback. And usually I put the ball back in their court. If it were you personally, what decision would you make? And I sort of start with that. If you were in my shoes with this disease at this stage, what would you do? And they're usually pretty straightforward about that. If it were me, this is what I would do. And not that I'd necessarily go that direction, but I'd say 9 times out of 10, I'm going to lean that way. So,
yeah, I think that, it's so important for myeloma patients to advocate for themselves. And really, it's almost like being a consumer of your own healthcare, right? So you need to know what you need, and then you need to be able to ask your doctor, what you need and what your goals are. There's people that really want to treat their disease very, very strongly, and they're worried less about quality of life. But then there's other people who may be at different stages of their life where they're more interested in quality of life right at this particular moment and being treated with something that's not going to give them too many side effects. So, everybody sort of has different treatment goals, but the most important thing is to speak plainly and communicate with your care team. Tell them what you're feeling, tell them the side effects that you're having, because if they don't know what's happening with you, then they can't help you with what's happening with you. So it's a really important point. I would really like to thank our 3 patients, Steve, Michael, and Jenny, for being with us today and talking to us about their experience as newly diagnosed patients. It was a great conversation. Thank you so much.
Thank you for listening to this episode of the Myeloma Matters podcast on newly diagnosed multiple myeloma, hosted by the Multiple Myeloma Research Foundation. The MMRF thanks Jenny Shaw, Steve St. John, and Michael Milano for sharing their stories and unique perspectives on their experiences with myeloma diagnosis and treatment. The MMRF also thanks AbbVie, BMS, Cure, Genentech, GSK, Janssen, Karyopharm, and Takeda Oncology for their generous support of this podcast. If you have additional questions about what you heard today, please call the MMRF Patient Navigation Center at 1-888-841-6673. If you've enjoyed this series, be sure to leave a comment or review wherever you get your podcasts. And thanks again for listening.